So, Dr. Bray, you ready to go? Awesome. Okay. Good morning, everyone. The Cloud CME activity code for today's grand rounds is 1534. Our speaker today, or first off, let me introduce myself. My name is Dr. Ty. I'm one of the OMM faculty members and program director for our OMM residency program. And to get the privilege of introducing our speaker today, Dr. Natasha Bray. Our program is underwritten by an undergraduate educational grant through the OSU Medical Center, Graduate Medical Education. A disclosure statement has been signed and is on file in the Graduate Medical Education Office. Dr. Bray is interim dean of the OSU College of Osteopathic Medicine at Cherokee Nation in Tahlequah. She previously served as associate dean in academic affairs at OSU Com at the Cherokee Nation since 2018. Dr. Bray also served as Associate Dean for Accreditation and is faculty at Tahlequah Medical Group Internal Medicine Program. Prior to joining OSU CHS, Dr. Bray serves as Associate Dean of Clinical Medicine at ARCOM in Fort Smith and Vice President of Academic Affairs Designated Institutional Officer, DIO, for Broward Health in Fort Lauderdale, Florida. Board certified in internal medicine and addiction medicine, Dr. Bray earned her Doctorate of Osteopathic Medicine degree at OSU Com and went on to Philadelphia College of Osteopathic Medicine and completed her internship as chief intern physician. Then completed her residency at Cambridge Health Alliance, Harvard-affiliated hospital. Dr. Bray has extensive experience in the development, accreditation, and delivery of educational programs for both undergraduate and graduate medical education. Dr. Bray serves on several national committees and has dedicated her career to medical education as a vehicle to serve vulnerable populations and improve the access to quality healthcare. So please welcome Dr. Natasha Bray.
Thank you so much, Dr. Ty. Good morning, everyone. So this morning, we're going to talk about osteopathic medicine and really the value add of practicing osteopathically to patient care in GME. Putting this talk together, you're going to see it is broken into a series of pieces. One is going to be the history and how we got to the development of osteopathic medicine, how we think about osteopathic philosophy and caring for patients, and then talking a little bit about where we are today in the practice care environment and why there's importance to continue to incorporate the philosophy of osteopathic medicine, but also how we all as osteopathic providers have a responsibility to advance the science and the knowledge around the practice of osteopathic medicine. So disclosures, Dr. Ty touched on some of these. I am currently the chair of the ACGME Council of Review Committee Chairs, which allows me the opportunity to serve as a director for the ACGME Board of Directors. I'm also a director on the NRMP, so the MATCH Board of Directors. I formerly was chair of the Osteopathic Recognitions Committee and vice chair of that committee, and served on that committee from 2015 through 2021 as we went through the single accreditation system. Most of the opinions you are going to hear today are my opinions based on my experience. They don't constitute any approval for any of those organizations which I serve as a board member currently. So I gave you a little bit of an overview of this, of how we're going to take our journey today and walk through some information. Just as a bit of standard setting for definitions and terms that I'll use, OPP refers to the osteopathic principles and practice. It's important to remember that this is a conceptual and practical understanding of the distinct behavior, philosophical, and procedural aspects of osteopathic medicine. A little bit different than OMM, which is osteopathic manipulative medicine, which is the skill set that we utilize to diagnose somatic dysfunction and then treatment using osteopathic manipulative medicine treatment techniques. A somatic dysfunction is present of one or more of the following physical findings: tenderness, tissue texture changes, asymmetry or restricted range of motion. And a structural exam is what you all learned while you were going through your education and how we assess physical findings for somatic dysfunction. So a little bit of background, and this is a very high-level overview of the history of medicine and is very much an incomplete history of OPP. So the history of medicine, if we look back historically, medicine was heavily bound in religion before the time of recorded history. So there was always this overlap between the practice of medicine and religious rituals. Medicine was thought to be visitation from the gods. So the gods would interact on people's lives, and medicine was a way of different gods coming in and saving and interfering in people's life. If we look at the code of Hammadi that was written in Mesopotamia in the 3000 BCs, it's really interesting because it says if a doctor treats a man with a metal knife or for a severe wound and caused that man to die, or has opened a man's tumor with a knife and destroyed the man's eye, his hand should be cut off. So there was very much this punitive because you were interfering with the will of God. Greek and Roman cultures marked really the beginning of scientific medicine, and Asclepius was first mentioned in Homer's Iliad. And if you remember, osteopathic medicine is represented by the rod of Asclepius and not the caduceus. Asclepius was a mythical figure of 535 BC and was looked on as a god. The cult of Asclepius found and built temples where the infirmed could go to be healed. So really this concept of bringing people in alignment with the gods to allow for healing. As we move forward in Greek and Roman culture, you get to Hippocrates, who was a Greek physician at 460 BC. And this is really who we look to as the father of medicine. He believed that medicine was intended to primarily assist nature in restoring balance and health. And if you think about osteopathic philosophy as we go through, this is very similar. We have an opportunity to allow the body, to allow nature to follow its course, and we just have to set the circumstances in the right way. Galen came along in 150 AD, and he really, most of what happened in Europe for the next 1,000 years was based on Galen's teachings. And then we fell into the Dark Ages from the fall of Rome to approximately 1500 AD, where medicine was controlled purely by the dogma of the church. Illness was really looked on as punishment for a wrong against God or an absence of God, and hospitals became deeply entrenched as part of the church. And we see this carry through even through into modern society. So if we think what happened after 1500 AD, you had Dr. Harvey come along in 1620, who really outlined and helped us understand heart and circulation. You had Leeuwenhoek in 1673 that invented the microscope, and we began to have an understanding of microbiology. Benjamin Rush in 1769 elevated the practice of medicine really to a science and started doing experiments and showing outcomes associated with it. Edward Jenner in 1796 developed the first smallpox vaccine in England, and Semmelweis in 1847 proposed that hand washing between patients would stop the spread of disease. One of the interesting things about this was he actually died in an insane asylum because he expressed his views publicly, and they did not concur with what the modern practice of medicine at that time existed of. So when we begin to think about the development of osteopathic medicine, we're entering the early 1800s, and physicians were really trained in a mix of an apprenticeship and formal study. Heroic medicine was what was acting at the time: bleeding, purging, leeches. George Washington died from a combination of upper respiratory infection and bloodletting. In 1799, the only available medicines at the time were alcohol, mercury, morphine, digitalis, marijuana, willow bark. And the germ era had really just begun to be recognized, that bacteria and infections were the etiology of a lot of the diseases that were killing people. And we became infatuated with this concept of disease. Physicians at the time weren't thinking about wellness or prevention. They were thinking about these microbes that were out there causing disease. So a few questions began to emerge. Why do not all who are exposed to an infectious agent get ill? And this is really the environment in which A.T. Still entered the picture. A.T. Still, who's considered the father of osteopathic medicine, was born on August 6th, 1828 in Lee County, Virginia. His father was a farmer and a Methodist minister and a physician. And his grandfather had converted to the Methodist faith and migrated to the United States. And his great grandfather was actually an Anglican bishop to the Queen in Bath, England. So A.T. Still did attend a traditional medical school that later went on to become the University of Missouri, Kansas City. And in 1851, he moved to Kansas to take over the Shawnee Indian Mission near Eudora, Kansas. And I want to pause as we talk about the history of A.T. Still to share, one of the things and aspects that we don't talk about as much. This comes from the autobiography of Andrew Taylor Still. It was written in 1908. And in his autobiography, he says, "In my early days in the windswept Kansas, I developed my attention to the study of anatomy. I became a robber in the name of science. Indian graves were desecrated and the bodies of the sleeping dead exhumed in the name of science. Yes, I grew to be one of those vultures with a scalpel and study the dead that the living might be benefited. My subjects were bodies exhumed from Indian graves. Day and night, I roamed about the country, often at moonlight and often in daytime with a shovel to disinter the dead Indian, utilize his body for the good of science. Someone says the ends justify the means, and I adopted this theory to satisfy the qualms of conscience. I love this study and have always pursued it with zeal. Indian after Indian I exhumed and desecrated, and still I was not satisfied. 1,000 experiments were made with the bones, and I became quite familiar with bony structures. Part of why I think it's so important for us to have an understanding of this history is we're going to spend time this morning together talking about osteopathic medicine, and a lot of it was based on A.T. Still's understanding of anatomy, but to be able to appreciate the good that he learned and what he's taught us, we also have to understand that this was learned on the backs and quite literally the bones of Indians who had been buried and whose graves were desecrated. So A.T. Still, as we said, was a minister. He was a teacher. He was a Union soldier. And what he began to see as he looked at what was happening in the 19th century, people were dying of cholera, smallpox, tuberculosis, and the medicines that were available to treat these people, what were considered best practices were bloodletting and mercury and alcohol-based compounds. And what he really felt was this isn't saving lives. This is causing more harm than good. This feeling was underlined by family loss. 3 of A.T. Still's children died of spinal meningitis in 1864. His first wife died of complications of childbirth and pneumonia. He had a newborn daughter die of pneumonia. So over a very short period of time, he lost 5 children, despite being a physician, despite having access to medicine. So as he moved through this, he continued to farm and preach. He studied and practiced medicine extensively. In 1874 is when he finally announced this osteopathic philosophy. And if you've read osteopathic history, they talk about he flung to the breeze the banner of osteopathic. And his intent at the time was really not to create a new profession. And I think that that's important for us to remember. He wanted to improve the present system of medicine. He wanted to give it a scientific basis. And that was where he based his study of anatomy. He really advocated deeply for good nutrition, regular sleep, regular exercise, and the role of proper spinal alignment to allow the body to heal. Shortly after his announcement, Dr. Still was prohibited from practicing or teaching medicine in the state of Kansas. A preacher in Macon condemned him as satanic for laying hands on patients as part of his treatment. So A.T. Still moved to Kirksville, Missouri in 1876, and he founded the first osteopathic school in Kirksville in 1892 under a charter that was granted by the state of Missouri. The American School of Osteopathy was founded on October 3rd, 1892. And from the very beginning, there was diversity of genders within his class. So 12 men and 5 women enrolled. A few years later, 5 years later, the American Academy of Osteopathy was founded. And by 1900, the school was the largest school of healing arts in the country. A.T. Still very famously said, "It's the object of a physician to find health. Anyone can find disease." And if we think about that, he really viewed the role of the physician was the opportunity not just to discover disease. The emphasis that he put on preventive care, wellness, primary care, and access to physicians to help people handle the stresses that their body were experiencing so that they could live healthy lives was extremely important to the philosophy very early. He felt like the physician must first ensure that what he is doing does not harm the patient. And now we're hearkening back to that Hippocratic oath in the philosophy of Hippocrates. It is usually not the physician that heals a patient. It's the patient's natural functions that produce wellness in normality and return to health. The physician's role is really only to discover and help these natural processes along their path. And that really speaks to why he advocated so adamantly for good nutrition, regular sleep, and regular exercise at a time where those weren't viewed of value. I know everyone on here knows the tenets of osteopathic medicine, but I think it's important for us to really pay attention to them and have that understanding that he did view the body as a unit that involved both the mind, body, and spirit, and that it was capable of self-regulation, self-healing, and health maintenance. Because of this, structure and function were interrelated, and rational treatment needed to be based upon an understanding of the basic principles of body unity, self-regulation, and the interrelationship of structure and function. So understanding OPP and separating it a little bit from OMT and the technical skill of treatment, the philosophy really looks at each system in the body has a self-healing, self-regulatory mechanism. So if we look at the cardiac system is made up of anatomy and physiology. There's muscles, there's valves, there's electrical conduction systems, there's local vasculature that's supplying those muscles and valves, and there's local biochemistry that is affecting it. Each of the systems is affected by other organ systems, though, that have self-healing and self-regulatory mechanisms. So the autonomic system, the biochemistry system in the body, lymphatics, as well as vascular volume and composition are affecting the cardiac system. And it's really important that the balance of these allow for self-healing, self-regulatory mechanisms that provide health maintenance or homeostasis. So these homeostatic mechanisms allow the systems to function in the presence of a stress or an allostatic load without any symptoms. So the more allostatic loads we add onto any system, the more stressors and the more likely it is to become symptomatic. So if we think of all the things that affect what is happening to the cardiovascular system, we have bad genetics, we have medication side effects, we have renal failure, we have lack of exercise, we have stress in our jobs, we have a poor diet. All of these things come together to impact what's happening in the cardiovascular system. And eventually the homeostatic mechanisms are overwhelmed and symptoms develop. So our interventions are indicated. Our job as a physician starts to treat or prevent overwhelming these homeostatic mechanisms that the body's experience. And we have lots of things that we can use for this. We have medications and pharmacology, we have surgery, we have OMT, we have education around lifestyle and how we make better food and exercise choices. We have behavioral and we have spiritual counseling. So thinking about this specifically about disease states, if we think about what happens in type 1 insulin-dependent diabetes, the pancreas has lost its ability to produce insulin. We treat with insulin because those homeostatic mechanisms are lost. So a little bit different than what the pathophysiology that happens with type 2 non-insulin dependent diabetes. The body has become resistant to insulin, or the pancreas just can't produce enough insulin to keep up with the body's demand. In this setting, we use medications to manage the condition while we work to restore homeostasis. We educate our patients on diet, exercise, and lifestyle management of their underlying condition. So if we think about the interrelatedness of all of the different organ systems in the body and how they come together, we can begin to think about, how do we address this? What are the roles of the vascular, the lymphatic, and the autonomic system to tie all of our other body systems together? The mind-body-spirit connection of how we integrate these different systems is really important in how we take into account the internal and external stressors that affect the allostatic load that's on the body, those stressors that we're seeing. OMT affects organ systems by reducing this allostatic load. It primarily acts on the musculoskeletal system to affect our autonomics, our vascular, and our lymphatic system. By normalizing the autonomic load, we're able to reduce the impingement of vascular and lymphatic vessels and affect the body's ability to heal and regulate itself. So if we look at a history of osteopathic medicine, and I told you we were going to jump around a little bit about where we are, how we got here, and where we're going, and what our opportunities are moving forward. We hit on the American School of Osteopathy was founded in 1892 in Kirksville, Missouri. Vermont became the first state to recognize the practice of osteopathy in 1896, followed by North Dakota in 1897. By 1910, more than 25 schools of osteopathy and more than 300 MD schools existed in the United States. AT still didn't have a lot of respect necessarily for all the osteopathy schools that had opened. In 1910, the Flexner Report came out, and only 8 osteopathic schools survived. By 1916, the number of schools was down to 6. That was Kirksville, Des Moines, Chicago, California, Kansas City, and Philadelphia. It's important to know it wasn't just osteopathic schools that were closed as a result of the Flexner Report. A large number of the allopathic schools in the country closed as well. If we move forward to 1915, the AOA recommended that osteopathic medicine become a 4-year course for medical school. And osteopathy really kind of moved along in 1929. Pharmacology and surgery became required parts of the curriculum. Osteopathy had gained a lot of recognition and respect during the flu epidemic in 1917 to 1919. Patients of osteopathic physicians had a significantly less, 16% less mortality, morbidity through the use of manipulative techniques. And over the next really 40 years, from 1920 to 1960, you saw a growth in osteopathy, but they struggled to gain professional acceptance, even though they had gained practice rights in most states, excuse me. Some other important things that happened in 1935, the AMA declared osteopathic medicine a cult and prohibited consultation with or consorting with osteopaths. And the AMA didn't recommend removing that ban until 1957. But even at that time, the recommendation was not adopted by the membership. This did a couple of things because the AMA prohibited consultation with or consorting with osteopaths. You saw a growth of osteopathic hospitals across the country that were independent from traditional hospital systems. You saw an emphasis of the profession on primary care that really served rural and underserved settings because there was little choice or opportunity to practice in urban settings. And groups of citizens in those settings who didn't have access to healthcare welcomed the physicians into the community. When we moved into the time of World War II, the military refused to recognize osteopathic degree and allow osteopathic physicians to serve in the military. And because this happened, what you saw is that a lot of the physicians were drafted, went overseas to work, and you had an opportunity for osteopathic physicians really to become the predominant providers within the communities. And this really led to wider acceptance of the profession. The majority of DOs in states like Michigan, Ohio, California, and Pennsylvania were able to provide medical care to factory workers that were really fueling the war effort. And the DOs became recognized and needed by the communities. By 1957, Congress passed laws allowing DOs to serve in the armed forces and as commissioned officers within the healthcare military establishment. However, the first ones weren't drafted or commissioned until 1965 as part of the physician shortage around the Vietnam War. So a lot of these things came together to really shape the history of osteopathic medicine. It wasn't until 1973 that DOs had achieved practice rights in all 50 states. The Hill-Burton Act provided funding for hospital expansion in the 1960s and 1970s and prohibited discrimination against osteopathic degree and osteopathic physicians. And this act declared that if institutions accepted federal funding, it had to equally grant privileges to osteopathic physicians, really important to the growth of the osteopathic profession. In 1962, the California Medical Association and the California Osteopathic Association agreed to merge, and DOs were offered the right to trade in their DO degree for an MD degree for $65. The vast majority of physicians, osteopathic physicians in California, accepted this offer. And by 1963, the DO degree was no longer recognized, and the licensing board was disbanded in the state of California. This was really a big deal. California had the largest DO College of Osteopathic Medicine in the country at the time. And University of California, Irvine took over the California College of Osteopathic Medicine and developed the first state sponsored MD program at the time. There was a lot of concern in action that suggested that the California solution would actually be the end of the profession. There were federal lawsuits that were filed at the time to stop other states from taking similar moves. And ultimately, the action was declared unconstitutional and was reversed. However, by 1965, only there were the 5 remaining colleges of osteopathic medicine. Keep in mind, we had lost California. We're graduating about 750 physicians per year. This was kind of the beginning of growth in osteopathic medicine. Between 1969 and 1979, we had practice rights in all 50 states. We were accepted by the military. We were recognized, and discrimination was prevented against the degree program for practice rights within hospitals and anyone receiving federal funding. And between 69 and 79, you saw 10 new osteopathic medical schools that were developed in Michigan, Ohio, West Virginia, Florida, California, New York, New Jersey, Maine, Oklahoma, and Texas. The interesting thing about these is for the first time, these were state-sponsored and state-supported schools. So really an important growth in recognition of the importance of our degree program. That kind of brings us forward to 2014, where we had acceptance of our practice rights. DOs were completing residencies all across the country in both ACGME accredited as well as AOA accredited residency programs. And we began to see some challenges with physicians who were completing AOA training programs not being accepted into ACGME accredited fellowship programs. And that's really what brought about the single accreditation system and the merger of the two residency program training systems in the country. A memorandum of understanding was signed in 2014, and the transition of AOA accredited programs to ACGME accredited programs began in 2015 and ended in 2020. So we'll come back to that in a minute, but where are we with osteopathic medicine in 2022? Today, 25% of medical students in the United States are training to be osteopathic medicine or osteopathic physicians. There is currently 34,000 medical students training to become DOs, and they're in 38 osteopathic medical schools with 60 training locations. To put this in perspective, when I started medical school in 1999, there were approximately 10,000 medical students. So the growth has really been astronomical. If we look at where DOs are going to train, the NRMP main match results in 2022. These are where our graduates of our osteopathic schools went. 24.5% went into internal medicine programs, 22.4% into family, 11% into emergency medicine, and you can see the percentages there. Overall, 56.4% of our graduating physicians went into primary care physicians, and 15.7% went into preliminary positions. So as I said, 56.4% of the class went into primary care. If we compare this to graduates of our MD schools in 2022, 39.5% of them went into primary care. So we still have a very primary care dominant profession. 70% of US citizen international medical grads went into primary care, and 73.9% of non-US citizens, IMGs, who came into the US training system went into primary care fields. Looking specifically at OSU's data, and this is data that you all probably know quite well, our class of 2022, 46.7% went into a primary care field, and 62.1% of our graduates matched into residency programs in Oklahoma, and 15.6% matched into rural residency programs. So let's go back to the single accreditation system and what happened to osteopathic medicine in the single accreditation system. There was concern that as we merged our GME, that we would lose osteopathic specific graduate medical education. And as part of the memorandum of understanding, ACGME created a system called osteopathic recognition. This is a set of requirements that lie on top of the regular program requirements and allow programs to formally offer education that promotes the use of osteopathic principles and practice within their specific specialty at the GME level. I'm not going to read this to you, but I think it's important. If you look at the requirements around osteopathic recognition, one of the things that comes forward is the tenets of osteopathic medicine that we touched on earlier are integrated into those requirements. So if we look at what programs have osteopathic recognition today, 258 programs have achieved osteopathic recognition for their programs. And again, we see a primary care predominance with 165, 165 family medicine programs, 27 internal medicine programs. There's 7 OB programs. But one of the things that I was very proud of when I was serving on the Osteopathic Recognition Committee is we're seeing a variety of other specialty programs who are adopting osteopathic recognition for their programs, recognizing that to practice osteopathically is so much more than just performance of OMT. If we look at Oklahoma and where we are in the state race, Pennsylvania has the most osteopathically recognized programs at 47, followed by Ohio and Michigan. The top 10 are on this slide. Oklahoma is at 21. I will say that we have the only diagnostic radiology program in the country with osteopathic recognition, and we were the first otolaryngology as well as psychiatry program and cardiovascular disease. So we've really done a good job in leading by our program directors in this space in establishing programs. So OPP in the clinical practice, and this is one of the things that I think is hard when we talk about programs and we talk about how we integrate osteopathic practice into care that's not OMT. I think we struggle sometimes in defining and quantifying and measuring what we mean by OPP. So I asked a question to a lot of my colleagues, and I said, what ways do you incorporate OPP into clinical practice that are not OMT? I'm going to give you a summary of some of the responses, and then I want to go through some of the specific responses to you because I think they really begin to tell a story of how we can think differently. So one thing I heard consistently from people is that osteopathic medicine is a holistic approach to medicine and treating the entire person and not just symptoms. And that's a catch line you'll hear describing osteopathic medicine. But the approach really looks at lifestyle. It looks at how an injury or an illness affects other systems and affects other overall health of the individual. And they help patients develop attitudes and lifestyles that don't just fight the illness, but really with a focus towards prevention. How do we help this person be healthy and achieve lifelong health? There was a quote, in every encounter, there's an emphasis on the body, mind, and spirit connection. Patients focus solely on the body when they're coming in to see us. But DOs spend time teasing out what barriers might be related to the other spheres of wellness so that we're able to treat the underlying cause of whatever the illness is that they're coming in. Other things that came through is an emphasis on disease prevention. Looking at the body's ability to heal or restore homeostasis. We help patients have the tools to do that. A lot of DOs talked about the improved palpatory skills that they learned in school and how they translated that not only to diagnosis of somatic dysfunction, but diagnosing of other illnesses and ailments. There was a sense of increased compassion and empathy, a emphasis put on patient engagement and patient-centered care approaches and shared decision-making to really partnering with patients, understanding the visceral somatic reflexes and that will help with a holistic approach. And then again, going back to those keys around communication. So a few quotes from anonymous DOs. Osteopathic physicians, we think and act differently. We simultaneously take information in many ways, verbal, physical, emotional. We make connections with it. People feel seen. I hear this from people in the community and the hospital staff all the time. We ask questions in a different manner and make connections so that we see the whole person before us. It makes great generalists, but our DR specialists also have those same skills. I think we learn to view our patients through a prism that illuminates all aspects of the person with the same intensity. We see more complete picture of who they are and what they're going through. We also ask students to be vulnerable and to touch each other. They create an intimacy with expectations to support and help that becomes habitual. So they go into OMM class and automatically ask each other, how are you? You look tired. Does it hurt? Can I do something to help you? That way of being of service stays with people and it gives them joy. Another great quote in A.T. Still's autobiography, he stressed that DOs listen to patients as people, do excellent physical exams, and continue to review your anatomy. I tell my residents how important it is to get to know the person and be more detailed in their exams, as testing seems to be replacing exam skills. This individual says, I don't know how to separate my osteopathic from being a family physician. She talked about having a patient referred specifically from a colleague for OMT mid-back pain, and she started at the beginning, history, and went through it extensively. The story just felt off. Her symptoms didn't sound musculoskeletal, and the physical exam, she had good range of motion and mild tissue texture changes, but it just didn't match the referral. This physician ordered imaging and discovered a renal cell carcinoma. And as she said, I didn't help her with OMT. I helped her by listening, by being open and asking questions, and by feeling with my hands that what I was feeling or was expecting to feel wasn't there. So sometimes our palpatory skills help us discover what's not there so that we go look for other answers. The last one that I'll share with you, and then I will share these slides and you can read them on your own. But in my highly scientific subspecialty practice, I worked with MDs and MD PhDs who were brilliant diagnosticians and surgeons. They were great at in vitro fertilization, IVF, but they never saw the person. They saw the patient with pelvic pain and assumed it was endometriosis, and they went to surgery. It worked most of the time. They never asked about a history of trauma, often sexual, sometimes not. Sometimes just guilt over being a sexual being that caused them pain. I saw those patients and soon was seeing more of them than my partners, who were much smarter than me, were with much more fancy academic pedigrees. They were both incredibly nice and sociable guys, one of them with more than 250 publications and decades of NIH funding. In the end, they taught me to be a better scientist, and I taught them to be more holistic, osteopathic, and we all lived together happily ever after. I'll let you read the rest of the quotes, but I think it's important. So we have physicians who see the value in their practice, but what does the literature say? And this is always where learners want to go, is there's not evidence to support the use of OMT. And I will challenge you in that. I'm going to run through, and I won't read all of these to you, but I want to demonstrate to you that there's a lot of literature that demonstrates the advantage of osteopathic manipulative therapy, but also OPP in the care of patients. So this study is looking at a comprehensive review of alternate therapies for the management of chronic pain, comparing acupuncture, Tai Chi, OMM, and chiropractic care. Next one is low back pain. The OMT regimen was associated with significantly and clinically relevant measures for recovery from chronic low back pain. Another low back pain study, migraine headache studies that suggest OMT may be considered a valid procedure for the management of migraine. Post-concussions, patients with headaches secondary to post-concussion showed immediate benefit in headache pain intensity after OMT. However, it's important that the sustained ability wasn't found in follow-up. Pneumonia, reduced lengths of hospital stays, duration of IV antibiotics, reduced incidence of respiratory failure or death. Preterm infants, OMT reduced length of hospital stay and hospital costs for preterm infants. OMT, we saw improvement in otitis media findings. Clicked past that one too fast for you guys, I apologize. Empathy. Interest in and use of OMM is associated with higher empathy scores and empathy subcomponents. Training and the use of OMM should be examined as a mechanism contributing to durability of empathy in osteopathic medical physicians. When you guys look at these slides, the QR codes will take you directly to those articles so that you can read them for yourselves. So we asked the question, is there value of osteopathic recognition to learners? And a study showed that 70% of third-year osteopathic medical students indicated that they wanted to train in osteopathically focused residency programs. Wonderful quote. I love OMT and I want to continue to use it in my practice. There's increasing literature base supporting the use of OMT in the emergency medicine field as a non-pharmacologic treatment for cervical radiculopathy and acute low back pain. So what value does it have for the residency programs? There's literature that demonstrates that it helps programs recruit residents that share their mission and interest in osteopathic patient care. Osteopathic care helps reduce medical costs, improve patient outcomes, and improve patient satisfaction. And it supports the continuation of osteopathic philosophy and its contribution to healthcare. And you can see quotes from different program directors that are included on the slide. So how do we integrate osteopathic philosophy, osteopathic care into our residency learning environment? And there's really a few opportunities that I'd highlight for you. We can think about focused rotations where people spend time with our OMM department, our OMM board certified, or NMM board certified colleagues, where they utilize OMT and OPP in most of their patient encounters on both the inpatient services and outpatient. They can have integrated rotations where it's integrated into the patient encounters as you see them. There can be dedicated osteopathic rounds where we go around and follow up on patients, clinic rotations, or even just having conferences and conversations like this, reminding us and supporting us in the care of patients and how we can approach patients osteopathically. So integrating OPP into clinical science, if you're educators, and I would argue that we all are, remembering the relevant anatomy and physiology, discussing the impact of our interventions, such as pharmaceutical and surgery, on the whole body, in addition to the intended outcome, thinking holistically and full scope of treatment for conditions and diseases. Talk about OMT when it's appropriate. As an example, where we really can integrate osteopathic principles and practice into care on internal medicine rounds, as you're prescribing a diuretic for urinary or a diuretic to an elderly patient for their heart heart failure, what impact does that have on their urinary incontinence? How does that impact the social life of an elderly patient who's no longer able to leave the house because they've got incontinence related to their diuretic use? And how do we begin to support that patient so that they're able to continue to have an active life and engage with their families? Another great example is thinking about dietary influences. How do we partner with patients to restore health? How do we think about how we counsel counsel patients to engage in that homeostatic mechanisms when they're becoming overwhelmed? How do we reduce those stressors on our systems? Diet is one, proper sleep is one, exercise is one. The ultimate goal of management is to help patients return to their state of health. The other thing really important, talk to medical students. When is it appropriate to eliminate medications and take patients off medications because we're able to achieve improvement in the patient's overall health? So other things that can be done, we talked about OMM experiences, but encourage the use of OMM when it's possible. Students, ask to do OMM. If you see a patient that you think would benefit, talk to your residents and talk to the attendings if they share your view and if there's an opportunity to provide that care to patients. Our preceptors, all of our residents and our faculty who are teaching in our programs, talk to the students, encourage them to use OMM when appropriate. Talk about psychosocial implications to the cases and how do the interventions that we do help restore health to our patients, help them engage in the priorities that they've set for their individual lives. Talk about taking people off medications, as I said, and train students to help partner with patients and motivate lifestyle changes. So as much as we need to create the learning environment and how we need to care for patients, we also need to contribute to scholarly activity. We need to support our learners in engaging in osteopathically focused scholarly activity so we continue to demonstrate the benefit of the care to patients. I will encourage you, there's lots of resources out there at OSU. We are very lucky to have a wide scope of library resources that are available for you to use. What constitutes osteopathic scholarly activity? This is directly out of the ACGME frequently asked questions. It needs to demonstrate evidence of creation or dissemination that promotes or integrates more than one, at least one or more of the osteopathic principles. So that mind, body, spirit interaction, structure, function, relationship, regulatory and self-healing physiologic mechanisms, or OMM and patient care. Don't feel like your osteopathic scholarly activity has to be OMT based. It can be OPP focused. Some examples is OMM treatment for allopathic physicians, providing a longitudinal curriculum. Durham 5, this is one of my favorite studies that's been published since the single accreditation system. It's a curriculum for dermatology residents and how they can incorporate osteopathic competencies into patient care. Establishing osteopathic assessment so we can do education-based programs. This is a development of an osteopathic recognition track in a pediatric program. So if you need ideas, here are some ideas for how you can incorporate osteopathic ideas into your scholarly activity. Looking at the rate of burnout or career satisfaction in DO physicians who do OMT versus DO physicians who do not. DO perceptions of osteopathic philosophy and practice. What does it mean? I gave you some quotes from some of my colleagues about what they felt it meant to practice OPP and to integrate it into their practice, but we could look at a larger perception and really begin to add to the literature and defining of what that truly means. Look at length of hospital stays in patients with whatever diagnosis who receive OMT versus no OMT. We can look at 30-day readmissions for lots of different diagnoses for patients who get OMT during the hospital versus no, or at follow-up visits. Look at growth trajectories for low birth weight infants who receive OMT versus no OMT, headache days. So we could go on and on about different opportunities for developing and integrating osteopathic philosophy into our practice. What I would encourage you is the osteopathic philosophy has changed dramatically since A.T. Still. We know that he emphasized the importance of empathy, the importance of lifestyle, the importance of nutrition, of proper sleep, all of those things to decrease stressors on the system to allow patients to heal. I would argue that this is as important, if not more important today as we work with and partner with our patients. In the last 3 years with the pandemic, we've seen people become disenchanted. They're disconnected from their communities. They've lost trust in the medical system. They're not sure who is promoting their health and who is giving them medicines or vaccines or things that they're concerned of that they feel may actually cause them long-term harm. We have a lot of work and opportunities to really continue to establish the importance of osteopathic medicine, the importance of seeing people and how they interact in their communities, how they interact in their families, how they interact with their own individual health and their own individual health goals. And as we work with our patients and we work in our communities and we work in our different specialties and we publish and we study, we are able to make sure that osteopathic medicine continues to be successful and continues to be available to patients. Patients value the care that they're receiving. With that, I will stop. I'm happy to answer any questions that anyone has. My contact information is on here for any of the learners out there who want to think about research projects. I'm happy to run ideas with you. I'm happy to help you find references within the osteopathic literature. So with that, I'm going to stop and I'm going to actually end the slideshow so that I can see people and I'm able to interact with you a little bit better. So if you want to put questions into the chat, you may do that. Or I'm looking at the chat now, or if you want to raise your hand, I'm happy to answer questions that way, whatever is easiest for you all. And Lisa, do you need to make any comments? I see a whole bunch of questions about attendance.
Dr. Bray, I have reached out to everyone that I have seen that had a problem. So my only comment would be if anyone still has any issues, just to email me and we will get it taken care of.
Thank you so much. All right, well, I am not seeing any questions. I will stay for a few minutes just in case, but have a wonderful day. Remember to take care of each other and remember to have at least a brief moment of reverence and respect for the work that we get to do and that patients actually trust us to improve their lives. Thank you all so much for allowing me to talk with you today.
Thank you, Dr. Bray.